Hi everyone, I'm Hussien Heshmat. I'm a professor of cardiology and interventional cardiologist, and I'm glad to be with you in today's meeting. And in the coming 20 minutes, we'll be discussing the relation between venous thromboembolism and malignant conditions. We'll be discussing the incidence of venous thromboembolism and cancer, the mechanisms, the outcomes of VTE and cancer, and what options do we have in hand for treatment. And before we proceed, let's start by two case vignettes that I recently encountered. The first is a 36-year-old lady with recurrent Ewing sarcoma, which is a high-grade malignancy that was metastatic in this patient to the brain, to the orbit, and to the lungs. She already had chemotherapy and excision of the tumor with some of the ribs. The patient presents to the oncologist with acute dyspnea. Her ECG doesn't show significant changes. She desaturates and the blood pressure drops. The heart rate rises from 80 to 120 beats per minute. And the oncologist was vigilant enough to suspect pulmonary embolism, and his suspicion was realized. This is the CT scan that shows a saddle embolus in the pulmonary artery bifurcation that is extending into the main branches of the right and left pulmonary arteries. Because of the poor capacity, the poor respiratory capacity, the poor reserve, and as you see here, ribs are excised, we went for catheter-directed ultrasound-assisted thrombolysis, the ECOS, with low-dose fibrinolytic over 12 hours. This resulted in rapid resolution of the symptoms and regain of the hemodynamics. After that, the patient was started on low molecular weight heparin, and then the question, what to do next? The second patient is a 47-year-old male smoker who was diagnosed with malignant thymoma that regressed with chemotherapy. The patient remained asymptomatic with almost normal examination, but he does a routine CT scan to follow up the recurrence of his malignancy, and I got called from the oncologist because they discovered that there is a chronic thrombus in the right descending branch pulmonary artery. And the patient was referred for opinion what to do about this silent thrombus in the right pulmonary artery. We discussed the options with the patient, of course, and we come to that later with a discussion. So what's the relation between cancer and thromboembolism? We know that venous thromboembolism is 7-fold higher in patients with malignancy compared to other patients. On the other side, cancer, even a hidden cancer, can be seen in 20% of patients with venous thromboembolism. So that's not uncommon to have venous thromboembolism in cancer. In those patients with cancer, venous thromboembolism is more aggressive. It's associated with 3-fold the risk of death, with double-fold the risk of bleeding, and with 3-fold the risk of recurrence. And some tumors are more commonly associated with venous thromboembolism than others, especially pancreatic cancer, ovarian cancers, gastric and bronchial cancers. And regardless of the classic Virchow's triad of the blood vessel, the hypercoagulable state, and the stasis of blood, several factors are associated with the risk of VTE in cancer, including advanced age, comorbidities, female gender, prior DVT. There are factors related to cancer, like adenocarcinoma being more common to cause venous thromboembolism, pancreatic tumors, as we said. Metastatic cancers are more likely to cause VTE than early forms of cancer. Factors related to treatment also come in action. Chemotherapy, as we see, will be associated with some increased risk of cancer, hospitalization, major surgery, etc. And among the malignancies, multiple myeloma is particularly notorious for venous thromboembolism because we know it's associated with a hyperviscosity state. We know that from percutaneous coronary interventions that the patients who are most sensitive to contrast-induced nephropathy are patients with multiple myeloma, because there is a tendency for hyperviscosity. Not only that, these patients are frequently obese, they have indwelling central lines, and some of the therapies are associated with VTE, especially the high-dose dexamethasone and the thalidomide group of agents. So we've seen that VTE and cancer is a notorious combination. Even when patients are treated, the risks of bleeding in cancer patients with VTE is more than threefold the risk compared to non-cancer patients. And of course, the risk of recurrent is also threefold. And the risk of VTE doesn't remain the same. There are periods of time in the life of a cancer patient where VTE becomes more likely, of course, during hospitalization and during surgery. When the patient goes into remission, the risk of VTE tends to go down. It's very important to note that surgery is associated with a sharp increase in the risk of VTE, and this increased risk is not only during the timing of surgery, but the risk remains up to 2 months after discharge, and this will have reflection and importance in the selection of the therapy and the extent how long should the therapy continue. A more or less relation is noted with chemotherapy. Again, the risk of VTE increases with chemotherapy, but it tends to decline within the first month after the start of therapy. How can we risk stratify patients for the risk of VTE cancer patients? We have a famous score that takes into account the location of malignancy. Of course, pancreatic and GIT get 2 points. Other cancers get 1 point. Anemia gets 1 point. Leukocytic count, platelet count, the body mass index, and we sum up the score. Patients with high risk scoring 3 or more points, then the risk of VTE is about 7%, and this will have implications on this will have implications on therapy. This scoring system does not apply for patients with brain tumors or multiple myeloma. As we said, multiple myeloma is a special case on its own. It has its own score for thrombosis called a saved score, taking into account surgery, Asian race, history of venous thromboembolism, dexamethasone, etc. Again, if patients score more than two or more points, it means that they are high risk for venous thromboembolism. So now I hope we understand the relation between cancer and VTE in terms of incidence, recurrence, bleeding, and how to risk stratify patients, which types of cancer are more associated. So how can we handle this situation? Which agent should we use in the different courses, in the different stages of the cancer patient? We have outpatient prophylaxis, we have prophylaxis of medical patients, we have prophylaxis for surgical patients, and we have treatment in patients who are either symptomatic or asymptomatic VTE. And these are the agents that we have: unfractionated heparin, low molecular weight heparin, fondaparinux, DOACs, Apixaban, eloxaban, rivaroxaban, dabigatran, warfarin, and aspirin. Which agent fits more into these 4 situations? Of course, we had only at one moment of time we had warfarin, and that was the only therapy for venous thromboembolism in patients with cancer. Until in the beginning of the century, as low molecular weight heparins started to become widely used, then trials in cancer patients showed that low molecular weight heparin was associated with a favorable effect compared to warfarin, and this was most commonly noted with dalteparin. So we realized that low molecular weight heparin was superior to warfarin in patients with cancer-associated VTE. They were more effective, and they were more or less similar to vitamin K antagonists in the risk of bleeding. That's why it remained for a long time a dictum and a dogma that patients with cancer-associated VTE, low molecular weight heparin is the preferred agent. But unfortunately, we know from our practice that it's very unlikely for patients to remain on low molecular weight heparin for a long time. It's a daily injection or twice daily injection, so there is the discontinuation rates are really high and patients can lose their protection. And then came, after the era of low molecular weight heparins, came the era of direct anticoagulants. And the earliest, the first agent was probably dabigatran. But there was an issue, a general issue for NOACs from the atrial fibrillation trials, that patients with malignancy were most likely excluded from trials of stroke prevention and atrial fibrillation. So we didn't know actually what to do. Then we started to see trials of direct oral anticoagulants in patients with VTE. In this study, dabigatran was tested versus warfarin for venous thromboembolism, and we see that the risk was similar, so dabigatran was as effective as warfarin with less bleeding, although major bleeding was the same. But the weak point of the RECOVER study is that only 5% of patients had cancer. So we cannot generalize the use of dabigatran in patients with cancer. One of the agents that started to prove its efficacy is Apixaban, and it was tested in the Hussien trial, and we found that the risk of venous thromboembolism was significantly lower with Apixaban compared to dalteparin. So that was the first time that we see an agent that was superior to low molecular weight heparin. But there was a downside, that the risk of bleeding was higher with Apixaban compared to dalteparin. This was not seen in all tumors, it was mostly seen in patients with GI tumors and genitourinary tumors. So one lesson that we will take as we go on is NOACs need to be taken with caution in patients with gastrointestinal and genitourinary malignancies. Rivaroxaban was tested in SELECT D, it was just a pilot trial, and we're starting to see the same trend. Rivaroxaban was associated with improved, reduced risk of recurrent VTE, but the risk of clinically relevant non-major bleeding was more with rivaroxaban. So we're replicating the same story. VTE is less, but bleeding is more. And again, patients with GI malignancies experience more bleeding with rivaroxaban, which is something expected because we have the same findings when we give rivaroxaban or some other NOACs for atrial fibrillation, for stroke prevention. GI bleeding is the Achilles heel of the use of some NOACs. But when looking at the meta-analysis, we find that rivaroxaban is non-inferior to vitamin K antagonist in terms of recurrent and in terms of bleeding. And looking at meta-analysis of all phase 3 trials of DOACs, we reach the same conclusion. Novel anticoagulants are non-inferior when it's compared to vitamin K antagonist, with major bleeding that is again non-inferior to vitamin K antagonist. So we know from these trials that instead of relying on low molecular weight heparin, we can rely on novel anticoagulants in venous thromboembolism. Then came Apixaban, and we know from trials of stroke prevention and AFib that Apixaban is one of the agents associated with the lowest risk of GI bleeding. So in this pilot trial, the ADAM VTE, they randomized patients with symptomatic cancer to Apixaban 10 milligrams twice daily for 1 week, then Apixaban 5 milligrams twice daily for 6 months, compared to dalteparin, an initial 200 international units per kilogram, then 150 units per kilogram. And the study found this was just a pilot to test the risk of major bleeding, because bleeding, as I said, is the Achilles heel of novel anticoagulants. And the study showed that major bleeding was not worse with Apixaban compared to dalteparin, but of course premature discontinuation was way more with dalteparin. This encouraged the investigators to go for a bigger trial, a multi-center trial, in 11 countries in 119 centers. It's called the Caravaggio trial. It included more than 1,000 patients. And patients with cancer and confirmed VTE were randomized again into Apixaban versus dalteparin. Apixaban 10 twice daily, then 5 twice daily, dalteparin in the same dose, and then they were observed for 1 month. They looked at recurrent VTE and they looked at bleeding, of course. And Apixaban here was a bit different from other NOACs, because not only it was associated with a tendency for superiority in terms of prevention of recurrent VTE, but the risk of major bleeding was not different from dalteparin. So it's probably the only agent that has a near better effect in preventing recurrence with no worsening of major bleeding. And probably it's the only agent up till now from the Caravaggio trial that was associated with some improvement in survival. Looking at the Kaplan-Meier curves, the event-free survival was better with Apixaban compared to dalteparin. How long should the therapy continue? We know that continuing for 6 months at least is protective, and we may extend beyond the 6 months. So what do the guidelines say? We've seen many trials. What do the guidelines say? We have in fact more than one set of guidelines. We have the American Society of Hematology, we have American oncologist guidelines for cancer-associated thrombosis, and of course we have our favorite European Society of Cardiology guidelines on cardio-oncology. Now there's a whole specialty that's in evolution. It's the cardio-oncology, and it doesn't only focus on the cytotoxicity of chemotherapy or on radiation-induced myocarditis or radiation-induced coronary artery disease. It also focuses on thrombosis in patients with cancer. So what do the guidelines, the European guidelines, recommend for the management of thromboembolism in patients with cancer? You can see that Apixaban, edoxaban, and rivaroxaban, they are all class 1A for symptomatic or incidental VTE, like our second patient. Low molecular weight heparin is also class 1A. In patients with cancer and platelet count less than 50,000, then here low molecular weight heparin takes the upper hand, although the weak evidence, and going for a half dose. And it's a class 2A recommendation to extend the therapy beyond 6 months. Multiple myeloma is a special situation, as we always said. For multiple myeloma and thromboembolism, then low molecular weight heparin is the preferred agent. And then comes aspirin in patients who are at low risk. It takes class 2A. Whereas Apixaban, rivaroxaban, they come at a weaker point compared to aspirin. So how would each situation, how would each agent fit each situation? First, the medical oncology patient who's ambulatory. In these situations, no routine thromboprophylaxis should be given, with exception for high-risk patients who have the score that we described earlier, 2 points or more. Then we have evidence of Apixaban, rivaroxaban, low molecular weight heparin if there are no risk factors for bleeding. Multiple myeloma, as I said, is different. We use low molecular weight heparin in high-risk patients. In patients who are low risk, then it's aspirin. The evidence for NOACs in this situation is weaker than aspirin. How about hospitalized patients who have malignancy or are hospitalized for pneumonia or for any other medical reason? Admission for chemotherapy or bone marrow transplantation, there is no need for routine thromboprophylaxis. If they are hospitalized for a medical reason, as I said, pneumonia, GI bleeding, pneumonia, or any other reason, then here low molecular weight heparin takes an advantage, while NOACs have just a weak recommendation. In patients who have contraindication to any blood thinner, then the pneumatic compression is the best option. So the hospitalized medical oncology patients, minor procedures, no need. They are hospitalized for a medical illness, then low molecular weight heparin takes an advantage over novel anticoagulants. Surgical patients, of course, we've seen how the risk of VTE rises sharply in patients with surgery. So all patients who are admitted for surgery should be offered pharmacological prophylaxis here. Low molecular weight heparin takes an upper hand. It should start pre-operative and should continue for 7 to 10 days. We even have a point for extending low molecular weight heparin up to 4 weeks post-operative, because we know that the risk extends beyond 4 weeks. So we've seen prevention in 3 situations: the ambulatory medical patient, the hospitalized medical patient, and the hospitalized surgical patient. How should we handle the treatment someone who's symptomatic or asymptomatic? We have many options. We can use low molecular weight heparin, unfractionated heparin, fondaparinux, or novel anticoagulants. Low molecular weight heparin are preferred, of course, because of convenience in the absence of renal impairment. Apixaban, edoxaban, they get category 1 recommendation. Rivaroxaban takes class 2A compared to low molecular weight heparin in patients without GI malignancies. We've seen that edoxaban was associated with a high risk of bleeding in patients with GI malignancy. For the long-term situation, we can use low molecular weight heparin, apixaban, edoxaban, or rivaroxaban. Beyond the 6 months, we can extend the prophylaxis in patients who are high risk, those who have metastatic disease or those receiving chemotherapy. A word of caution: with novel anticoagulants, we need to take a look at some drug-drug interactions because they are important. Other words of caution for novel anticoagulants: try to avoid in GI malignancy, in genitourinary malignancy, history of recent bleeding, or within 7 days of major surgery, when platelet count are less than 50,000, severe renal dysfunction, or GI comorbidities. How do we manage failure? If someone gets VTE while on fondaparinux, consider heparin-induced thrombocytopenia, switch to unfractionated heparin. Recurrent VTE on warfarin, then switch to low molecular weight heparin or NOAC. For recurrent VTE or NOAC, then switch to low molecular weight heparin, fondaparinux, or warfarin. And the guidelines stress on the point that asymptomatic VTE, like our second patient who had a thrombus in the right descending pulmonary artery, this should be treated in the same manner as symptomatic VTE. So to conclude, novel anticoagulants compared to vitamin K antagonists are non-inferior. Low molecular weight heparin compared to vitamin K antagonists are superior, and the risk of bleeding with some agents is comparable. So to recap, VTE is common in cancer. It tends to be more recurrent, with more bleeding and more lethal. We have risk stratification tools for solid tumors, risk stratification tool for multiple myeloma. For ambulatory high-risk patients, novel anticoagulants take the upper hand. For surgical prophylaxis, low molecular weight heparin takes the upper hand. Hospitalized patients, low molecular weight heparin. For treatment, we can use heparin or novel anticoagulants. We have strong data for apixaban and slightly less for edoxaban and less for rivaroxaban. Avoid novel anticoagulants in patients with GI malignancy, genitourinary malignancy, and high risk of bleeding. Multiple myeloma is a separate, distinct entity. For low-risk individuals, we use aspirin. For high-risk individuals, we use low molecular weight heparin. Novel anticoagulants are class 2B. Thank you for watching. You can find the lecture on the channel. You can scan the QR code. It will take you to the channel. And thank you for listening again. Hope to meet you in person. And if you have any questions, I'll be glad to answer.